for us today is none other than Dr. Abha Majumdar. I think she doesn't need much of introduction to this audience, but she's got many credits, medals, laurels to her, and the couple of important things which I would like to highlight on is she had a Lifetime Medical Excellence
Can you project
Award.
her? Okay.
2014 and Abdul Kalam Gold Medal Award in 2015, and she's a member of editorial board of IVF Worldwide, and she's a peer reviewer of Journal of Human Reproductive Sciences and member of advisory board for Journal of Fertility Science and Research. With this introduction, I introduce Dr. Abha Majumdar, and the stage is yours.
Very much for the kind introduction, and thank you, Dr. Reddy, for having me over. This was such an interesting conference with such a lot of exchanges of thoughts, ideas, and evidence that I am privileged to be here today. I am going to talk on stimulation for IVF in patients with diminished ovarian reserve. Can you all hear my voice?
Yes, ma'am.
Thank you. So when we talk about this, this is the only segment of patient which really intrigues us. We are always worried, oh my goodness, this looks like a poor responder, or maybe this has a low reserve, or this patient, why did she become a poor responder? She looks so normal. So it's very important to know that diminished ovarian reserve or poor ovarian reserve is different from diminished ovarian response or poor ovarian response. I'm using the word poor here instead of diminished. We'll go ahead with this. Poor ovarian reserve means the test for ovarian reserve show a poor reserve such as low ovarian volume, low AFC, low AMH, and slightly higher basal FSH, age which is more. And we always feel beforehand, we have that thing inside us that yes, she is going to respond poorly. Whereas on the other hand, we have patients whose ovarian reserve test look okay, basal FSH is normal or maybe a little higher, but then after we've stimulated for IVF, the response is poor in terms of number of oocytes collected. So what happens when we give ovarian stimulation? Then a woman who has poor ovarian reserve shows poor response. It looks all right. Okay, this was expected. But when the reverse happens, that means normal ovarian reserve shows poor ovarian response, that is where we get worried and we do not know what to do. However, came in Fertile Sterile 2016, the concept of a low prognosis group was made by means of Poseidon classification. This took over the Bologna classification, which was made earlier, because it had certain things which did not explain young women with good reserve and yet being poor responders. So here, as you see, the picture very clearly depicts on the left-hand side are two pictures of young women. On the right-hand side, two pictures of older women. So group 1 is adequate ovarian reserve, young woman. Group 2 is older woman with adequate reserve. Then we come to group 3, which is poor ovarian reserve, young woman. And then we come to group 4, older woman with low reserve. Now, when we look at all the criteria, then the age division mark is 35, AFC 5 or equal to 5, AMH 1.2 nanogram is the cutoff. So anything which is 1.2 or over is known as adequate ovarian reserve. But in the poor ovarian reserve, AFC has to be less than 5, AMH has to be less than 1.2. So even if it is 1.1 or 1.19, then also it comes into the poor ovarian reserve. So we have age, we have ovarian biomarkers, and then the number of oocytes retrieved in previous ovarian stimulation cycle. So Poseidon classification can only exist if we've done stimulation and we've retrieved oocytes. Now let us see, what did they try to do? What have we tried to do for treatment of patients who were expected to be poor responders or were poor prognosis group? So there has been just this. Either we use an antagonist protocol with flexible regime or GnRH long protocol. Nalini had very nicely said that we make the best cohort with GnRH long protocol and we can stop it to add antagonist later on. or milder stimulation regimes. This had become very prominent about a decade ago. The only thing which is very, very important is that whatever protocol we use, especially the antagonist protocol, pre-treatment for a better cohort is mandatory, which can be done either by the use of oral contraceptive pills from day 2 for at least 14 days, minimum of 14 days, or 21 days. Or we can use estradiol valerate in two divided doses, 2 milligrams twice, from day 22 till the menses comes, so that it doesn't let the pituitary release any FSH to start stimulating follicles from the follicular pool. Or we can also use progestin for 5 days from day 21, but then we have a 5 to 7 day progesterone free period, which does bring the endometrium back to normal, but also releases some of the follicles from the cohort. The other important thing is higher doses of FSH are recommended for this group, and use of additives like luteinizing hormone, HMG, or androgens to the COS protocol is included. So when we say milder stimulation regimes, I just wanted to bring your attention. Why did this go away 10 years ago? Because data from Human Fertilization and Embryology Authority collected between 1991 to 2011 had more than 591 fresh IVF ICSI cycles, where 584 were stimulated cycles and 6,168 were unstimulated cycles. Almost 50% of unstimulated cycles, no oocyte was relieved. So cycle was cancelled then and there. What else do we see in this? To achieve a live birth, 3.5 times more unstimulated IVF cycles were required compared to stimulated IVF. So this regime was sort of slowly discarded, and we came up to good ovarian stimulation, good number of oocytes, and that was the answer to patients who were poor prognosis patients. Now, group 1 and group 2, both young and old, but have a good reserve, ovarian reserve. But then, as expected, the older age is going to have poor quality oocytes because of the age interfering in the ploidy of the oocytes. And the group 1 would have good quality oocytes because these are younger women. What are the possible reasons of suddenly, a normal responder landing up with poor response? Low starting dose of gonadotropin, maybe our calculation went wrong. Asynchronous development, polymorphism could be underlying for the FSH receptor or the LH beta 5 receptors, or there was some issue in the trigger, or even in the oocyte collection, possibly our pressures were not well maintained, or whatever must have happened. Same thing happens in the group 2, the older women also, low starting dose, everything was similar. What is the treatment in both the groups? Well, when you go ahead in another cycle, then first thing you would want to make a good cohort. So if you're giving antagonist, then either you prime it with estradiol valerate or OC pills or progestin. A second thing which has been recommended, use recombinant FSH instead of urinary products, because they appear to be sturdier in action and they have a constant action. Another thing is make the dose of FSH higher and add LH. And you do this for both, whether they are young or old. And duostim, I'll talk about this later, is another method which is coming up for women who have appeared to be poor responders despite having a normal ovarian reserve. Rest of the things are all right, but I want you to see the measure of success. In a young group 1 Poseidian girl, we will need at least a minimum of 5 mature oocytes to produce one euploid embryo, whereas contrary to this, in the older woman, we would need 10 to 12 mature oocytes for one euploid embryo. So we need more for the older age. Same thing now, if we look at group 3 and group 4, again, young and old, poor reserve, both sides. Now, possible reasons are same as in the previous one for both. The treatment is same, but here possibly addition of androgens, diostim, and in the older group, addition of recombinant LH, androgens, and diostim all come into play. And the measure of success is again the same, 4 to 7 oocytes for one euploid blastocyst in the younger girl, whereas in the older age, we would need more than double number of oocytes for one euploid blastocyst. Now here, I just want to now summarize all what we learned in the Poseidian group. In poor responder, our aim is to collect more oocytes under antagonist or agonist protocol. So our basic thing is increase FSH dose from the previous cycle. Two is you could add additives. And what are the additives we are talking about? Androgens, LH, HMG. HMG was not discussed in the Posidian group because probably they was influenced by the LH molecule, which was their own, and hence HMG was not even tried over there. Duostim is an excellent strategy to increase the number of oocytes in a given period of time. So we'll go one by one on each of them. Increased FSH dose, and we know that low prognosis owing to decreased number of oocytes and thus lower clinical live birth rate is very, very obvious. When you see oocytes 1 to 3, the live birth rate is only 21. We don't regard age here at all. The moment we go on increasing the number of oocytes, we find that the pregnancy rates go up higher and higher. So having said that, we also have to remember that our cohort may look very good, but then the follicular output rate could be different for a lot of patients. Now, when we use AFC as a cutoff point to decide a dose, and we want to predict that we should get so many oocytes, for any given AFC, there is a potential oocyte yield, but it can be altered. How? By the stimulation strategy and presence of ovarian resistance to stimulation due to genetic polymorphism. So it could be sometimes very high AMH, which could make our stimulation resistant, or it could be genetic polymorphism. And we all know that exogenous FSH consumption is higher in carriers of FSH R variants and 5 beta LH variants for ovarian stimulation. Having said that, let's look at AMH also. We rely all our results, or we decide our doses on AMH. There is inconsistency in AMH measurement, and it is not only the assay, it is of biological origin. And if you see the median and range of anti-Mullerian hormone results in each individual, you'll find a big range over there, which goes up to, in picomoles, it goes up to almost 10 picomoles and come down to 2 picomoles. So there is a variation which is 19%, range 0 to 71%. Similarly, also the assay has variations. So non-equivalence of anti-Mullerian hormone automated assays, clinical implication for use as companion diagnostic for individualized gonadotropin dosing. So higher AMH values using the Axis assay by an average of 10% than with the Elixis assay. So 30% of women would have received an inappropriate dose of FSH if we would look at the Axis assay. So here is the difference, that we don't know which assay is being used by which lab, whether how much do we rely, what is the bench life of the test which is kept over there, whether it is refrigerated or it is left on the bench top. All that produces a little change in the AMH values, and any value which changes even from 1.1 to 1.2 nanograms will change the category of the patient. So this is a very nice paper which shows the effect of dose adjustments in a subsequent cycle of women with suboptimal response following conventional ovarian stimulation. I'm not reading the whole thing, but here only suboptimal responders were taken. That means 9 oocytes or less with adequate ovarian markers who had the same stimulation protocol and used the same or higher initial dose of the same type of gonadotropin compared to the previous failed IVF attempt. And what was the result? The result was the number of oocytes retrieved was significantly higher in the second IVF cycle. Read the last sentence. A regression coefficient of 0.02 for the starting dose implies that an increase of 50 international units of the initial recombinant FSH dose would lead to one more oocyte. So this is how you can calculate that you increase the FSH dose, but then it is very important to know that there is a ceiling for FSH dose, and especially this was used in girls who had a normal reserve of ovary. If there is a low reserve, there is no way that increase in dose will really lead to a similar increase in number of oocytes. Then we look at additives, and for this always used to intrigue me, that which additive should I use in my low responders. So we conducted a study to see the effect of addition of either letrozole or recombinant LH or HMG to a fixed recombinant FSH dose in poor ovarian reserve patients undergoing COS for IVF. So these were all Posidian 3 and 4 patients. None of them belong to the Posidian 1 and 2. And I only want to bring to your attention that this was the only study which showed a comparison between these three. In fact, it was rebuffed from one or two publications also earlier. But then, because they said that, you've used very unequal type of additives. But why these additives? Recombinant LH increases amount of androgens for conversion to estrogens and enhances FSH receptor expression and responsiveness to FSH. HMG contains both FSH and LH in a similar ratio, and LH activity is mainly drawn by addition of small quantities of HCG, which again increases the androgen substrate. Letrozole increases follicular response by increase in intraovarian androgens, thus amplification of FSH receptor expression and responsiveness. And how did we use them? We divided 120 patients into three groups. Group A received recombinant LH75 in addition to 300 units of recombinant FSH. Group B received 150 units of HMG, and Group C received letrozole 2.5 milligram right from day 1 or 2 of menses, one day even before the gonadotropin could be started, for 5 days. And I just want to show you the outcome. This is a large paper, but I'm just showing you that I was surprised. I thought letrozole was doing much better on a daily basis when I was looking into my patients' results and number of oocytes. But at the end of the study, we found that recombinant LH addition showed significantly important p values, which were significantly higher. Even though the numbers are small, this did give me a little idea and about the LH of efficacy of LH. And we have come to a sort of a lying statement that yes, LH is good additive in poor responders, especially if the reserve is low. And if you see here, I've only highlighted that ART women may benefit in this paper, which is a systematic review. uh, mm, ART women may benefit from recombinant LH supplementation during OS, especially patients with sufficient pre-stimulation ovarian reserve parameters that have an unexpected hyporesponse to FSH monotherapy. In these cases, recombinant LH can be started either during the mid-follicular phase to rescue the ongoing cycle, or on stimulation day 1 in a subsequent cycle. So here comes a paper where they say that they have good reserves, but unexpectedly she became a hyporesponder. Their LH can be a good substitute in a subsequent cycle from day 1, and in the same cycle, suddenly we find on day 6 that the response is less, then LH can be added. Similarly, the role of recombinant LH in women with hyporesponse to controlled ovarian stimulation, a systematic review and meta-analysis concludes. In conclusion, our analysis confirms that women with hyporesponse to exogenous gonadotropins might benefit from LH supplementation. Having said that, I would come to uh, the last one, DO-STIM. Now, DO-STIM means, as the word goes, DO-STIM protocol is double stimulation, and it is best suited for low ovarian reserve. That means AMH less than 1.5, AFC less than 6. I would say I should have said AMH less than 1.2. Poor response in the previous IVF cycle with less than 5 oocytes obtained, and need for PGT of embryos to be accumulated more embryos before sending them for genetic testing. So DuoStim has become a very favorite protocol of mine now. And I will tell you how good it is, because the second cohort is always better, and I always recover more oocytes in the second stimulation compared to the first, and the reason is also there. Well, this is follicular versus luteal phase ovarian stimulation during the same menstrual cycle in a reduced ovarian reserve population results in similar euploid blastocyst formation rate. So this was the new insight into ovarian reserve exploitation, which was published in 2017, the Shanghai Protocol. And this might look a little confusing to you, because here they've used clomid or letrozole in conjunction with gonadotropin in the first half of the cycle, collected all the oocytes, and then again used the same one after the first half. And they've given any trigger, may it be GnRH agonist or HCG trigger, because all these are antagonist cycle. But lately, what has been suggested and what we are doing, I'm going to tell you. From day 1 to day 10, say the patient has been on recombinant FSH or FSH plus LH, maybe with a little androgen priming in the beginning. We do the oocyte pickup, stop for 3 to 4 days, do nothing else. Here, a GnRH agonist trigger is better, because the follicles don't stay for long, and the luteal cyst tend to disintegrate within 3 4 5 days only. So they don't interfere with the assessment of new follicles coming up. Whereas if we give a HCG trigger, the only problem which happens that these luteal cysts stay for 10 12 days, and that interferes with identification of the new follicles which are coming up. We start stimulation again with the same drug, and then it just takes about 1 day extra, and we go ahead, and then now this time we can give a GnRH agonist trigger again, and then go in for a OPU. Both the cycles, oocytes have been fertilized, embryos made, collected, and by the end of the whole cycle we know how many embryos. I have made two small modifications in my own treatment regime. I like to give a dual trigger in the second cycle. Sometimes even in the first stimulation I give a dual trigger, because I don't care about the corpus luteum cyst which are there, but yes, they do interfere in monitoring. And two, I have stopped using antagonist in the second cycle. I just start medroxyprogesterone acetate 10 milligrams 48 hours after oocyte collection till the day of second trigger. And in all the cases I've done, now I've done quite a number of cases like this, I have recovered good number of oocytes with no LH surge happening. I've done no monitoring of these patients, just started it, called them straight away after 8 days, because I had an idea in the first follicular phase how many days are they going to take to make their the a big cohort of follicles. And if you call them early, you wasted your time, their time, and all the blood tests and ultrasound, because you would hardly see anything after 5 days. Now, having said that, this is luteal phase anovulatory follicles in the same patient they did, and they compared. The summary answer was the cohort of oocytes obtained after luteal phase stimulation are larger than the paired follicular phase stimulation derived cohorts and show a comparable competence, thus resulting in a larger mean number of blastocysts. Why
Sorry to
do
interrupt, ma'am. Last
I'm
2 minutes.
finishing. This is the last slide. So why do we get a larger number? Is because the cohort is there. There has been total suppression, by the hormones which the patient was getting. So there's no time for release of those little follicles from their cohort, and we go into this. So I would conclude to say controlled ovarian hyperstimulation under any protocol has similar results. Use of antagonist protocol requires pre-treatment to make a good cohort, whereas a agonist protocol already makes a good cohort, and if the agonist can be stopped and gonadotropins given individually, antagonist can be added again later in the cycle. Increasing dose of gonadotropin in a subsequent cycle is important because we are not testing for polymorphism. Changing from urinary gonadotropins to recombinant 1 is a good strategy. Upper limit of gonadotropin is mandatory, as injudicious increment is wasteful. Androgen precursors, HMG and LH. Now, androgen precursors, people have explored different things, whether it is letrozole or it is testosterone or it is DHEAs, are three most useful additives, but LH appears to fare better. Duostim is a very good strategy for controlled ovarian stimulation for women with low reserve to optimize oocyte numbers, and for those where PGS is desired. So I would end with this, that the real voyage of discovery consists not in seeking new landscapes, but in having new eyes for what you already have. Thank you very much.
Thank you, madam, for that excellent talk and explaining very beautifully about this dual stem, which is upcoming in a big way now.